Testing, testing. This meeting was called for 2 o'clock. We're waiting for some of our colleagues to join us. We told them we're going to start the meeting at 2:15. I'm putting everybody on notice that we're going to start this meeting at 2:15. Meeting of the committee will come to order. This afternoon, we will hear from the distinguished Secretary of the Department of Health and Human Services, Kathleen Sebelius. She will testify on the health proposals in the President's fiscal year 2011 budget, for which her department has responsibility. This responsibility is daunting. The department she leads has a budget of over $900 billion in fiscal year 2011. The programs that her department administers will directly affect the nation's public health and will ensure access to needed health care by over 100 million Americans enrolled in Medicare, Medicaid, and the Child Health Insurance Program. As President Obama reminded us on Monday, our nation is at war, and our economy has lost 7 million jobs over the last 2 years. The deficit that greeted this administration stood at $1.3 trillion. Our successful efforts over the past year to rescue the economy and the financial system from collapse have unavoidably added to that deficit. We clearly need to solve the deficit problem, but we can't do it overnight, and the President's budget wisely does not try to do so. The budget strikes a careful balance, helping unemployed families by creating jobs and protecting them against the loss of health insurance, investing in next-generation health care technologies, and taking steps to reduce the deficit while protecting the most important investments. In the health area, the President's budget recognizes that certain investments are essential while the economic recovery is still underway. The budget supports the enactment of health reform, which will provide affordable coverage for over 30 million uninsured Americans while reducing the unsustainable rate of increase in health care costs. The budget recognizes the need to protect the ability of America's seniors to see their doctors by repairing Medicare's physician payment system. The budget provides additional help to states that are struggling to maintain their Medicaid programs in the face of increased demand and reduced revenues. The budget increases funding for community health centers to provide cost-effective primary care, and it invests in prevention and wellness activities to improve the nation's health and to reduce the need for expensive medical care. The budget increases resources for FDA that will enable the agency to improve its oversight of medical products, strengthen its food safety efforts, and implement its new responsibility for tobacco. It is the duty of Congress to consider the President's budget proposals as it makes its spending and revenue decisions for the coming fiscal year. Secretary Sebelius is here to assist the members of this committee in carrying out that responsibility by giving us a better understanding of the proposals and their rationale. Through this conversation, we can together make federal health programs work as effectively and efficiently as possible, and I look forward to hearing from her. I want to recognize for the purpose of an opening statement the ranking member of the committee, Mr. Barton, for 5 minutes.
Mr. Chairman, before I do that, I have a parliamentary inquiry.
The gentleman will make his parliamentary inquiry.
What is the position of the chair for today's hearing in terms of opening statements by members on both sides of the aisle?
We will divide the opening statements equally between the chair of the full committee, the chair of the subcommittee, the ranking member of the full committee, and the ranking member of the subcommittee. And we will then go right to the hearing with the secretary. After that, every member will have an opportunity for 5 minutes. They can use that for their statements. They can use that for questions. They can use it however they see fit. But under the rules adopted by the committee, we anticipated that there would be an occasion like this where, while we ordinarily like to let members have opening statements, we just can't accommodate all the members that would like to make opening statements and be able to get to the secretary and to meet everybody's schedule. I regret that. We've made accommodations, notwithstanding the rules, on a number of other occasions, but we're going to have to stick tight to the rules at this time.
Mr. Chairman, so what you're saying is that the only members that can make an opening statement are the two chairmen, the chairman, the subcommittee chairman, the ranking member, the full committee, and the subcommittee, and no other member. Is that correct? Yes,
and I would include Mr. Dingle, which we've always done in all of our hearings.
Based on that, Mr. Chairman, I would move to postpone the hearing.
Motion before us to postpone the hearing. All those in favor of the motion say aye.
Aye.
All those opposed say no. The noes have it, and the motion is not agreed to.
Mr. Chairman, on that, I would request a roll call vote.
I'd like to ask the gentleman to refrain from doing that. We do have the secretary here. We try to accommodate you. We're not doing this out of any malice or meanness. We try to accommodate Dr. Burgess in his requests. We've tried to accommodate people in opening statements. Usually we try to get the meeting started early so that we can do opening statements. We're not able to do that today, and I think it's self-defeating.
I oppose the rule that you implemented at this.
But you lost.
We did lose. But I have the right to request a roll call vote, and I'm going to do that, and that is within the rules. We could work this out, but if you've chosen to not do it, then we're going to use the rules that we have.
Okay.
So I request a roll call vote.
Gentlemen, request a roll call vote. The chair is going to inquire of the parliamentarian if this motion.
Well, we thought we were going to start about 2:15, so.
The clerk will call the roll.
Mr. Waxman?
No.
Mr. Waxman votes no. Mr. Dingle? Mr. Markey? Mr. Boucher? Mr. Pallone? Mr. Pallone votes no. Mr. Gordon? Mr. Gordon votes no. Mr. Rush? Ms. Eshoo? Ms. Eshoo votes no. Mr. Stupak? Mr. Engel? Mr. Engel votes no. Mr. Green? No. Mr. Green votes no. Ms. DeGette? Ms. DeGette votes no. Mrs. Capps? Mrs. Capps votes no. Mr. Doyle? Mrs. Harmon? Ms. Harmon votes no. Ms. Schakowsky? Ms. Schakowsky votes no. Mr. Gonzalez? Mr. Gonzalez votes no. Mr. Inslee? Ms. Baldwin? Mr. Ross? Mr. Weiner? Mr. Matheson? Mr. Butterfield? No. Mr. Butterfield votes no. Mr. Melanson? Mr. Melanson votes no. Mr. Barrow? Mr. Barrow votes no. Mr. Hill? Ms. Matsui? Ms. Matsui votes no. Mrs. Christensen? Mrs. Castor? Ms. Castor votes no. Mr. Sarbanes? Mr. Sarbanes votes no. Mr. Murphy of Connecticut? Mr. Space? Mr. McNerney? Ms. Sutton? Ms. Sutton votes no. Mr. Braley? Mr. Braley votes no. Mr. Welch? Mr. Welch votes no. I'm sorry, Mr. Welch is not present. Mr. Barton? Mr. Barton votes aye. Mr. Hall? Mr. Upton? Mr. Mr. Upton votes aye. Mr. Stearns? Mr. Deal? Mr. Deal votes aye. Mr. Whitfield? Mr. Whitfield votes aye. Mr. Shimkus? Mr. Shimkus votes aye. Mr. Shadegg? Mr. Blunt? Mr. Blunt votes aye. Mr. Boyer? Mr. Radonovich? Mr. Boyer votes aye. Mr. Radonovich? Mr. Pitts? Mr. Pitts votes aye. Ms. Bono-Mack? Ms. Bono-Mack votes aye. Mr. Walden? Mr. Terry? Mr. Terry votes aye. Mr. Rogers? Mrs. Myrick? Mrs. Myrick votes aye. Mr. Sullivan? Mr. Murphy of Pennsylvania? Mr. Murphy votes aye. Mr. Burgess? Mr. Burgess votes aye. Ms. Blackburn? Ms. Blackburn votes aye. Mr. Gingrey? Mr. Gingrey votes aye. Mr. Scalise? Mr. Scalise votes aye. Mr.
Be recognized.
Mr. Rush? Mr. Rush votes no. Mr. Weiner?
Mr. Weiner?
Mr. Weiner votes no. Mr. Space? Mr. Space votes no. Mr. Dingle? Mr. Dingle votes no. Mr. Markey? Mr. Markey votes no.
Have all members responded to the call of the roll? Mr. Shadegg?
Mr. Shadegg votes aye.
Mr. McNerney?
Mr. McNerney votes no.
All members respond. Clerk will count the votes and announce them.
25 to 16, I think.
On this vote, Mr. Chairman, the ayes are 17, the nays are 25.
17 ayes, 25 noes. The motion is not agreed to. Mr. Barton, do you wish to have an opening statement?
I wish to have another parliamentary inquiry based on the opening statement.
Gentleman, state his parliamentary inquiry.
Under the chairman's prerogative, you are not allowing opening statements except for two members on each side, the chair, the subcommittee chair, the ranking of the full, and the subcommittee.
And Mr. Dingle.
And Mr. Dingle. Within that group, are members allowed to sublease their time so that if I didn't, for example, if I don't want to use my 5 minutes, can I sublease a minute to Dr. Gingrey and a minute to Dr. Burgess under your ruling, as long as I don't take more than 5 minutes total?
I have no objection if you want to use your time and distribute it to other members, but we have to stay within the time.
I understand that.
Mr. Chairman, parliamentary inquiry.
Yes, gentleman, state his parliamentary inquiry.
Mr. Chairman, I understood that when each of us get our 5 minutes, we can either make a statement or we can ask questions.
Absolutely. That's, of course, after the Secretary testifies.
Okay. I just wanted to make sure that we will have the chance to either make a statement or ask questions. So thank you.
Without objection, the chair will yield to Mr. Barton his 10 minutes.
Well, 5.
Your 5 minutes.
I'll take 10, Mr. Chairman.
We'll yield to you your 5 minutes.
I'll take 20 if you'll give me 20.
Well, you've already taken a lot of time.
Well, I think it's important that members on both sides, Mr. Chairman, have
Gentleman's recognized for 5 minutes. It's his time to do with as he sees fit.
I will make this statement. The little exercise that we just went through is to give every member of this committee an opportunity to talk to the President's designee for health care before she gives her opening statement. And I think that's important for every member of this committee on both sides of the aisle. I strongly disagree with the rule that was implemented at the start of this Congress. I can't prevent its implementation because the majority did vote to give Chairman Waxman that power, and he's used it. I think he's used it mistakenly, but he does have the right to do that. Having said that, Mr. Chairman, we're delighted to have our Secretary of Health and Human Service before us. We have received the President's budget, and we understand that she's prepared to explain that budget. We also hope that she'll be willing to answer some questions about what the President intends to do in terms of his health care policy, given what's happened in Massachusetts and in the other body. With that, I would be happy to yield to Dr. Gingrey for 1 minute if he would wish to make a brief opening statement.
Mr. Chairman, I thank the gentleman for yielding. Madam Secretary, thank you for being here. The President's $911 billion budget request for the Department of HHS represents a 10% increase in spending over last year's budget. While there are some laudable things included in this proposal, this budget rests on cutting $500 billion from the Medicare program. These cuts, according to Madam Secretary, your chief actuary of the Medicare program, will, and I quote, result in less generous benefits and might result in physicians who treat Medicare seniors ending their participation in the program. end quote. 11 million seniors enrolled in Medicare Advantage plans, roughly a quarter of all Medicare beneficiaries, are at a considerable risk, and they will incur hundreds of dollars in annual cost increases to make up for these cuts. Trimming the fat from the program is one thing, but gutting the program is certainly another. Mr. Chairman, let me say again, our seniors' health care program and their pocketbooks should not be used as a piggy bank to fund a government one-size-fits-all takeover of a health care system. And I yield back the time, and I thank the gentleman for yielding.
I'd now like to yield to the Vice-Ranking Member, Mr. Blunt of Missouri, 1 minute.
Thank you, Mr. Barton, for yielding me. Frankly, Mr. Barton and members of the committee, I think this budget does not accurately reflect our current economic situation. The so-called spending freeze doesn't even go into effect until next year. The budget has a complete lack of detail when it comes to Medicare cost containment, much less detail than the budget the President submitted last year. There are also discrepancies that make the administration's goals unclear because this budget seems to assume that health care reform would already be enacted. I'd be interested particularly to hear why high-risk pools are excluded from the budget and what the administration's plans for these programs will be. Currently, this program serves thousands of Missourians that otherwise would be uninsured. I'd like to see it expanded rather than eliminated from the budget, and I hope to learn today that that's not the goal of the budget, even though the budget excludes high-risk programs, and I yield back.
Is there anybody else on my final minute and a half that wishes to say something before I finish up? Seeing no hands raised, let me conclude my time, Mr. Chairman, by simply saying that when the President was sworn into office at our first meeting in the White House, he promised a health care reform package that wouldn't add one net dime to the national debt. As we all know, the plan that has come out of the Congress, or at least out of the House, is a huge unfunded mandate. We're interested that in this particular budget that's been presented, it appears that there'll be even more spending on health care. We don't see how that is reconcilable. We do know that over 60% of the population in this country has expressed their disapproval of the plan that is languishing, the different plans in the House and the Senate. We would hope, Mr. Chairman and Madam Secretary, that the President will reach out to everybody on both sides of the aisle, start over, and deliver an honest bipartisan effort to try to get a health care plan that is affordable, it is real reform, and it does provide more health care for more Americans. With that, Mr. Chairman, I yield back the remaining 10 seconds of my time.
Gentleman yields back his time. Mr. Pallone.
Thank you, Mr. Chairman, and I want to welcome the Secretary here this afternoon. We always enjoy it when you visit the committee. It's often said that budgeting is about setting priorities. How do we allocate our resources to those things that we value? And this is no easy task, especially amid concerns of rising deficits and debt. But it's clear to me that based on the President's budget proposal, health care remains a top priority for this administration, and I'm happy that this is the case because, as we all know, the health care problems that American families face are getting worse and need our attention. Millions of Americans have lost their jobs amid the recession and with it access to their employer-sponsored health insurance. In order to help provide some relief to these families, last year we passed the American Reinvestment and Recovery Act, which included additional money to help maintain state Medicaid programs in the face of increasing enrollment and fewer state dollars. In addition, we provided laid-off workers with a new 65% subsidy to help them purchase COBRA coverage. As unemployment stubbornly hovers at 10%, we need to maintain these safety net programs. That's why I was glad to see the President's request for an additional $25.5 billion to extend the temporary FMAT increase, as well as another extension of the subsidy for COBRA continuation coverage. Now, these immediate investments are critically important to making sure those families who continue to fall on hard times have the support they need from Washington. But this budget also plans for long-term investments in our health care system. For example, the efforts already underway and the investments the administration plans to make in the area of health information technology, or HIT, will help modernize our health care system, thereby improving the quality of care, improving efficiency, and lowering health care costs in the long run. And Madam Secretary, this budget builds on a lot of our accomplishments from last year. That much is clear to me. But as you know, there's still a lot more to be done. We must rein in out-of-control health care costs that are choking America's working families, businesses, and the government. We need to improve access to affordable and quality health care coverage for the millions of Americans who are currently without health insurance or on the verge of losing the coverage that they currently have. And we need to put an end to the abuses and outright discrimination used by insurance companies to deny people the care they need and increase their profits. In sum, we need a comprehensive health reform bill. And I look forward to working with you and the President on the many priorities laid out in this budget, especially enacting comprehensive health reform this year. I thank you, Mr. Chairman, and also the Secretary for being here today, as always. Thank you.
Thank you, Mr. Pallone. Chair recognizes Mr. Deal, the ranking member of the subcommittee.
Mr. Chairman, I have 5 minutes. Could I allocate time also among members?
The gentleman is recognized for 5 minutes to use as he sees fit.
Thank you, Mr. Chairman. This budget proposal, of course, leaves many unanswered questions. One, of course, is the question of the impact of the proposed health care reform legislation that is still pending. The budget, as I see it, leaves a placeholder with a projected savings of $150 billion. But there are certainly questions relating to that. We know that the original proposal was to cut Medicare and help pay for the cost of any proposed new legislation. Be interested to hear what the Secretary says with regard to the administration's position on that. Also, the budget appears to write off almost $400 billion in anticipation of the SGR fix. And we obviously would be interested in knowing what is going to take the place of SGR and whether or not that new program would anticipate curbing overutilization of Medicare services. But for many of us, Medicaid is one of the biggest areas of concern. Under this budget, the federal share of Medicaid outlays would be $297 billion for FY 2011. That's a 7.8% increase over FY 2010 and a $95.4 billion or a 47.4% increase over FY 2008 spending. That is of concern as we see the mandated expansion of Medicaid under the proposed bills that are now still pending. Those are concerns as to how the government and states, of course, too, are going to be expected to pay for those expanded coverages. I'll yield at this time 1 minute to Mr. Shimkus.
Thank you, Mr. Deal and Madam Secretary. Welcome. Today, we're in the process of increasing the debt limit on the floor of the House. I think it's the 5th time that we've increased the debt limit since the Democrats have been in control of Congress, and we're doing so again. Instead of freezing, can't we find 1 penny on a dollar savings across the board in federal spending? Just 1 cent of a dollar. I think we can, and that's why we have difficulty with this budget. You know, the discretionary end, as you know, is only about 1/4 of the budgetary spending. If we're not talking about the entitlement programs of Medicare and Medicaid, we're not addressing the real problems that we have in this catastrophic budget deficit and the debt that we're incurring. And as you know, on the entitlement programs of Medicaid, as we expand, which these health care plans do, we force the states to pay in more money that they don't have. So we have a lot of questions, Mr. Chairman. I wish we had more time, and I look forward to the rest of the questions that we have to offer. And I yield back.
You have 1 minute, Mr. Murphy.
Thank you, Madam Secretary. Thank you for being here. Sometimes not a pleasant thing to be in front of members of Congress, but I just thought I'd make a recommendation of something that hopefully you have some power and control to do, and that is, as we look at health care issues, one of the things that I think is so important is looking at how we can save money. Not deal with health care by raising taxes, not deal with health care by spending more, but sometimes look at our Medicare and Medicaid programs. As you know, they were founded in the 1960s and have thousands of things they pay for, but none of us still drive a 1965 car, we hope not, unless it's been overhauled a few times. There are still incredible inefficiencies in those programs and things that unfortunately take an act of Congress to change, such as, and things that are not there yet in some programs. We should be doing more with coordinating care. The paperwork, the procedures, the prescription errors are still a problem for us. It takes months to get a motorized wheelchair. If someone gets some emergency medicine and then they need more until a prescription arrives, the amount of paperwork physicians have to do, it just adds more to that. There's home infusion therapy is still not permitted, even if someone is capable of doing that. That takes an act of Congress to change too. So I hope that you will use your leadership and your position to help streamline a lot of this. And quite frankly, I think we can save billions of dollars and tens of thousands of lives by making things better in this whole process. And there, I think we'll see an awful lot of savings which you can use to deal more with health care in America. And with that, I yield back my time.
I'd be glad to yield any other members on the Republican side who want time. If not, I'll yield back my time, Mr. Chairman.
Gentleman yields back his time. Mr. Dingell, do you wish to make an opening statement?
Mr. Chairman, thank you. I'd like to welcome the Secretary to the committee. Her father, as we all remember, was a distinguished member of this committee and this body, and her father-in-law was a distinguished Republican member of the Congress. Welcome. And in the interest of time and out of respect for my colleagues, I ask unanimous consent to insert my statement in the record.
Thank you, Mr. Dingell. Well, Madam Secretary, we're delighted you're here. We have been looking forward to hearing from you. We wished we'd been able to hear from you earlier, but we're delighted to recognize you now and to have you make such statements as you wish to make to us about the budget matter. There's a button on the base of the mic. If you would press it in.
Chairman Waxman, Chairman Emeritus Dingell, Ranking Member Barton, Representative Pallone, Representative Deal, and members of the committee. Thank you for inviting me here to discuss the 2011 budget for the Department of Health and Human Services. We think the budget builds on the themes that the President laid out in his State of the Union: strengthening security and opportunity for America's working families, investing to build a foundation for future growth, and bringing a level of accountability and transparency to government. It abides by the pledge to root out programs that are redundant and obsolete. And under this budget, we seek to provide the health and human services that Americans depend on more effectively and more focused results. We'll make necessary investments that our country has been putting off for years, including investments in fighting healthcare fraud, strengthening our public health infrastructure, and getting serious about prevention and wellness. The budget is a major step toward a healthier, stronger America, and we think that this budget and comprehensive health reform will make families healthier, create jobs, and give them the security and stability they need. We're firmly committed to health insurance reform, and as the President reaffirmed, we're always willing to listen to ideas and work with anyone who's interested in finding a comprehensive solution to the health care crisis. Reform is still the best way to help millions of Americans without health insurance and millions more who are underinsured or who have a pre-existing condition. It's still the best way to help Americans who are just a pink slip away from losing their insurance. The administration continues to reach out to members of Congress, doctors, nurses, hospitals, and other key partners in this effort. But the investments we're making in 2011 support the goals of reform, improving America's access to the high-quality health care they need. And I look forward to discussing the importance of these reforms with you, but I want to give you just a brief overview of the budget priorities for this year and then look forward to the questions. From day one, the President said we need to put science first, and that's really how our departments run. It's reflected in the budget, whether it's fighting a pandemic or protecting food safety or transforming the healthcare system with electronic medical records. The investments we're making are guided by some of the best scientific and medical experts in the world. We're also guided by a constant vigilance about using taxpayer dollars wisely. At the time when so many American families are scraping together every last dollar to pay their medical bills, fraud, waste, and abuse are unacceptable. And that's why this budget contains an historic investment in cracking down on the healthcare fraudsters who steal from taxpayers, endanger patients, and jeopardize Medicaid and Medicare's future. The investment allows us to build on efforts that began last May when the President asked the Attorney General and me to put together a new fraud task force known as HEAT. It's an unprecedented partnership bringing together high-level leaders from both departments to share information, spot trends, coordinate strategies, and develop new fraud prevention and prosecution teams. A year ago today, we expended access to millions of children through the CHIP Reauthorization Act. In 2009, we know that 2.5 million more children who were previously uninsured got health care coverage from Medicaid or CHIP. Now, part of that landmark legislation contains funds to help us reach out to the approximately 4 to 5 million children who are eligible but not yet enrolled in those critical programs. We're also investing new funds in what I consider to be the backbone of the American healthcare system, community health centers. Thanks to this investment, the neighborhood centers will provide high-quality primary care for 20 million people a year, 3 million more than were able to be served in 2008. The budget ensures up-to-date care for seniors and people with disabilities who depend on Medicare. On top of that, we have almost $1 billion in funding to strengthen and support our country's healthcare workforce. We increase funds for the Indian Health Service. American Indians and Alaska Natives historically have not gotten the care they've been promised and deserve, but we're working to change this because regardless of race, ethnicity, gender, disability, or geography, every American deserves high-quality, affordable care. We're investing in next-generation healthcare technologies to help providers raise the quality of care for all Americans. The adoption by doctors and hospitals of electronic health records reduces medical errors, helps coordinate care, and cuts costs and paperwork. This budget does assume a 0% update for physician payments. Everyone agrees that the scheduled Medicare physician payment cuts are not sustainable and would seriously damage access to care for Medicare beneficiaries. So we're recognizing this as an honest budget that reflects Congress' continued action in this area. And we look forward to working with you, Mr. Chairman, and your committee to develop the payment policy to give physicians incentives to improve quality and efficiency. Our budget's based on our growing understanding that health is influenced by many factors outside a doctor's office. Where you live matters, what you eat and drink matters, even what you watch on television. And to help more Americans live healthy lifestyles, the budget continues the work of rebuilding the public health infrastructure. What we have today is overwhelmingly a sick care system where we wait until something goes wrong to intervene. We're trying to build a true health care system. To that end, the budget creates a new program at the Centers for Disease Control and Prevention that will work to reduce the rates of disability and morbidity due to chronic disease in 10 of our biggest U.S. cities. It will allow us to begin the serious fight against obesity, a problem costing our healthcare system almost $150 billion a year. There's a significant increase to help us build a 21st century food safety system to go along with our 21st century food market, where nearly half our fruit and over 3/4 of our seafood come from overseas. We're expanding the efforts of the new Food Safety Working Group that I co-chair with Agriculture Secretary Tom Vilsack. The additional funding allows us to update food safety standards, enhance surveillance and response, and hire 350 additional food inspectors. It makes a serious investment in our battle against smoking. The budget provides significant funds for educating children about the dangers of smoking and new research to help us develop better ways to stop Americans from smoking. While we continue to do the steady work of promoting health care, we also need to prepare for public health emergencies, whether their cause is Mother Nature or our fellow man. And some of the best defenses are medical countermeasures, vaccines, treatments, respirators, among other things that help reduce the spread of infections, reduce health consequences, and ultimately save lives. This flu season, we got a wake-up call about the readiness of our countermeasures, even as our scientists and private sector partners scrambled to produce a safe, effective vaccine in 6 months, 3 months faster than it usually takes. We saw temporary vaccine shortages because the vaccine grew slowly in chicken eggs, an unpredictable process we've used for the last 50 years. So the budget includes $500 million to upgrade countermeasures. Just as important, it contains significant funds for NIH, for research that continues many of the breakthroughs that make these countermeasures possible. We're also undertaking a comprehensive review of our entire countermeasure production process, from laboratory to the doctor's office, and we'll have a report to give this committee later this year. Strengthening America's health is half of our mission, and our budget goes a long way to restoring health security for Americans. But the other half of the mission is providing security and opportunity for America's working families. Middle-class families aren't just taking care of their children these days, and we've provided some additional help with child care, but they're also often dealing with aging parents. 80% of the long-term care services in this country are provided by family members. Great for older Americans to be cared for by their loved ones, but often financially and physically exhausting for caregivers. So there's significant new support for those family caregivers, including counseling and information about how to best care for elders, adult daycare centers to help drop parents off for a day, and transportation help to get seniors to the doctor or the grocery store. The investments help give caregivers relief and help them keep their loved ones at home as long as possible. And finally, the budget extends relief that we provided last year for states and communities facing budget cuts across this country, helping states maintain essential supports and services at a time when working Americans need them most. So there's no question that hardworking people of this country have been tested over the last few years. As President Obama said in his State of the Union, we urge Americans to rise to the challenges posed by our current difficulties and pledge that as a country we'll face these challenges together. We're closer than ever to passing health reform, and we intend to work with you to finish the job for the American people. The 2011 budget will support and enhance reform, making long overdue investments to strengthening our health care and public health systems, keeping all of us healthy and more secure, while targeting relief directly to working Americans who need it most. My department clearly can't accomplish any of these goals alone. It will require all of us working together. Thank you, and I look forward to your questions.
Thank you very much, Madam Secretary. That was an excellent review of the budget. I want to start off the questions. First of all, I want to say how pleased I am with the President's continued commitment to health care reform. It's a goal that we share. I know that you've done a lot of thinking about how to make sure that we're ready for reform and that your budget reflects critical building blocks in that effort. Members of this committee have been particularly concerned to make reform work, and we need to ensure access through more health centers and training of health professionals, and to take advantage of new health information technologies, and to recommit to prevention and public health. I want to ask you some specific questions, however, about Medicare. There are two critical priority areas I see in this particular area. First, we need to improve Medicare coverage of prescription drug costs by filling in the donut hole in the drug benefit. Seniors should not have to go without needed medicines due to lack of coverage. And second, beneficiaries must be able to get the care they need from their physicians, and that requires fair and predictable payment. So we must permanently reform the broken physician payment system in Medicare. Could you elaborate on the administration's policies in these two areas?
Certainly, Mr. Chairman. I think that the donut hole, the reduction of the excess costs that too many seniors have to pay when they reach their limits in the prescription drug program are parts of both the House and Senate plans on health reform. They are not repeated in this budget. We are assuming that we will move ahead on health reform and have those as part of the critical future. But as you know, it's one of the most serious issues for seniors across this country, and way too many people hit that gap and don't have the wherewithal to pay 100% out of pocket for the drugs that keep them out of the hospital and keep them well. The most serious challenge facing Medicare beneficiaries right now is the 21% scheduled budget cut to their doctors. I talk to doctors every day, I talk to seniors every day, and they tell me that that isn't possible, that we would have a system guaranteeing health care for seniors and cutting those payments. Our budget assumes that over the next 10 years we will not cut those payments 21%. We look forward to working with you, Mr. Chairman, to find the specific policy. As you know, both the House has addressed this plan in the past. We look forward to both the House and Senate addressing it, but it is a problem looming facing the 43 million Americans who depend on Medicare benefits. If that kind of cut were to occur, we would not have providers to deliver those essential services.
Well, I'm pleased that you're committed, as we are, to deal with both of those issues, and we have to find the way to do it. I want to ask you a question about Medicaid. When unemployment goes up, families lose their incomes and their health insurance, so the need for Medicaid increases. At the same time, state revenues necessary to pay for Medicaid decline. To help states maintain their Medicaid programs during the recession, the Recovery Act we enacted last year included a temporary increase in the federal Medicaid matching payments, or FMAP. Each state received at least a 6.2% increase, and states with very high unemployment received more. This temporary FMAP increase will expire at the end of December. Unfortunately, many states are still expecting high unemployment and sharp declines in revenues well into 2011. The President's budget recognizes this problem and requests an extension of the FMAP increase through June 2011. The House has twice passed such a 6-month extension, once in the health reform bill and once in the jobs bill. My question for you, Madam Secretary, is what happens next January if we fail to extend this FMAP increase? What are the implications for state budgets, for health care providers, for health care workers, for Medicaid beneficiaries?
Well, Mr. Chairman, as you know, I came to this cabinet position directly from a governorship in the state of Kansas, where I served until the very end of April last year. So I was a governor cutting the very budgets you talk about, and I can tell you from my personal experience how the stimulus package, the Recovery Act funds, not only helped us to make sure that we did not have to slash essential benefits at a time when additional Kansans needed those benefits, but in fact saved jobs. State budgets are largely education funding and health care funding. Those are often somewhere between 75% and 90% of the budget. If we did not have those additional resources to help keep health services, in fact, we would have laid off teachers, we would have laid off correctional officers, highway patrol, jobs all over, because there's no place else to get that money. So not only is it an essential service, but I think it's directly related to thousands of jobs in my state and hundreds of thousands, perhaps millions of jobs around the country. Every governor in this country, and I have talked to my former colleagues on a regular basis, describe this as one of their top priorities, the continuation of the FMAP assistance into through June of next year, which is a state fiscal year. This will get most states through their next fiscal year, and I think it is absolutely an essential part of our recovery moving forward. And absent that, the modest progress now being made in states that they hope will be more significant progress over the next several months, focusing on jobs, on new development, on innovation, will take a major step back.
Thank you very much. Mr. Barton.
Thank you, Mr. Chairman. And thank you, Madam Secretary, for being here. Before I ask questions, let me just compliment you on one part of your budget, or the President's budget. The budget for the community health centers was increased $290 million. That is something that I think most Republicans support. I know I do. The community health centers in my district do excellent work, and they do it very efficiently. So I want to be positive about that, and I'm sure that you're very supportive of that too. Back in September, myself and Congressman Walden, the ranking member of the Oversight Subcommittee, sent you a letter about the use of Title 42 funding. Title 42 gives the Health and Human Services Department the ability to pay certain of its employees above the general schedule to attract the very top talent at NIH and in certain research situations. This Title 42 authority is explicitly limited to Health and Human Services. In the last 10 years, over 3,000 employees have been given this designation by HHS. Some of them make well over $300,000 a year. That in and of itself is not necessarily a bad thing. I think it is something we need to look at in the terms of tight budget authority. But my question today and the question in the letter, the Environmental Protection Agency is now using Title 42 authority. And my question to you first is the EPA now part of Health and Human Services?
Not to my knowledge.
Okay. Is the Surgeon General a employee or a part of Health and Human Services?
Yes, sir. That Surgeon General is always, I don't know always, but certainly is a part of our department under the Office of Public Health and Science.
Would the Surgeon General, could you construe the administrator at EPA to be the Surgeon General?
No, sir. We have a Surgeon General.
Okay. So we're in
Regina
agreement
Benjamin
on that.
is the Surgeon General of the United States.
Okay. Then why in the world do you allow the Environmental Protection Agency to use Title 42 authority, which is explicit to your department, to create a program at EPA to put their employees in this special designation by the hundreds of people? Are you aware that that's happening?
Sir, I'm aware of your letter, and I have had some discussions with the staff, and we are, trying to get the most complete answer we can. But as far as I know, there has been no explicit or implicit designation of authority to the Environmental Protection Agency.
You just gave more information in the last 30 seconds than we've gotten in the last 6 months.
Well, as I say, a series of events. I was not here. I don't know when this practice started. We are working on your letter. We want to get you a thorough and complete answer. I don't want to be, I'm telling you what I know at this point, but we will fully answer your letter. And
Well, I have another copy of the letter. I'm more than willing to give it to you again. We have a situation where the Environmental Protection Agency appears to be completely without authority to set up a program. They even have a manual, apparently, at the EPA on how to convert their employees to Title 42 employees. Now, you just said, rightfully so, and I commend you for being honest, that the Environmental Protection Agency is not a part of HHS, and the EPA administrator can in no way be construed to be the Surgeon General. So you understand the law. My request is that you now enforce the law with the EPA and answer the letter, which we sent copies to Mr. Waxman and Mr. Stupak, Mr. Walden and I, so we can stop this practice. I mean, do you agree with me that the EPA should not be setting up a Title 42 program since Title 42 is explicitly designed to give some additional financial encouragement and compensation to our highest scientists and researchers at NIH and FDA?
Mr. Barton, what I can assure you, I will thoroughly investigate this, and I will get you a complete answer to your letter as promptly as we possibly can.
My time's expired, Mr.
Gentleman's time has expired. Mr. Pallone?
Thank you, Mr. Chairman. Madam Secretary, I mentioned in my statement, in my opening statement, and I think mentioned both FMAP, the FMAP increase, and the COBRA subsidy have been critical in helping Americans who have been hard hit by the recession. Chairman Waxman already asked you about extending the FMAP increase, which I support, but I wanted to also ask you about extending the COBRA subsidy, and essentially what would be the impact if we didn't make this COBRA subsidy expansion. Not looking for numbers, but just generally why that's important and what would happen if we didn't do it.
Well, Congressman Pallone, I think that as you well know, COBRA is an effective tool, but often not financially viable for way too many folks, particularly folks who have lost their jobs in a downturn. The opportunity to purchase 100% of their previous coverage is a nice offer, but often out of reach. So what this bridge program allows is, with some additional help from the federal government, workers who are laid off and their families can continue to have essential health services. Again, absent health reform, which could create an alternate, more viable, more affordable market, this is an essential way to make sure that hardworking families who have lost their job through no fault of their own continue to have health services.
Well, let me say, I do hear from a lot of these people because, as you know, before we made the current extension, there were a lot of people that were in danger or actually already had. I think there was a week or so there when some actually had lost the subsidy, and many of them did, call my office and say they wouldn't be able to continue their coverage. Do we have any idea of the numbers that might not be able to make that 100% without the subsidy? We have any idea? Maybe you could get back to me on that.
I would be glad to. I think it's likely, though. A laid-off worker is almost guaranteed not to be able, unless they have a huge nest egg, to be able to pay out of pocket for 100% of the previously covered employer costs.
So you think it's actually almost, maybe not 100%, but very close to it?
Well, that was certainly, again, not only my personal experience talking to people, but what I saw across the country, that's, they're scrambling to pay rent, buy food, and unfortunately health insurance is often something that they have to go by the boards as desperately as they would like to continue it. It just isn't a viable option.
Well, thank you. Let me ask about S-CHIP also. As you know, well, actually today literally marks the one-year anniversary since the President signed into law the CHIPRA program, which, was a variation on S-CHIP that we passed, in the last year or so. And I'm particularly proud of that legislation because we worked on a bipartisan fashion to increase access for, I think, about 11 million children. Can you tell me how implementation of CHIPRA has gone over the past year? How has insurance coverage and the quality of the coverage improved for kids, and how have you been working with the states to increase coverage and improve retention rates?
Well, what I'm pleased to report, Congressman Pallone, is that in spite of the downturn in the budget of most states across the country, state leaders are seeing ensuring our children a fundamental piece of making sure we have a healthy, prosperous future. So states are actually increasing coverage for children. Many states have actually increased the threshold of the poverty level for whom the CHIP program applies. Congress, I think, wisely provided some outreach funds. So we have put those funds in the hands of state leaders and state partners to actually try and enroll kids. It's one thing to have them eligible. It's another thing to find and enroll children. And those partnerships are very creative and underway with faith-based communities and medical outreach centers, with community health centers, with I just did an event today with Secretary Vilsack looking at the opportunity to try and make sure that enrollment is as easy as possible, and if a family is signing up for the supplemental nutrition programs, they also can sign up their children for health insurance. And what we know is about 2.5 million additional children in the years since CHIPRA has been extended have been signed up and enrolled, again, in spite of very difficult budget times, and I think that's good news.
Oh, that's a very good news, and I thank you for all your efforts in those outreach programs. I think are particularly important. Thank you.
Gentleman's time has expired. Mr. Blunt.
Thank you, Mr. Chairman. Madam Secretary, thanks for being here today. I'd have said that earlier, but I was in a rush to get my 1 minute in about a couple of things I'm concerned about. Something you mentioned earlier about the donut hole in Medicare Part D. You said too many seniors have to pay because they get into this donut hole. Do all seniors pay that get into this donut hole, or are poorer seniors at some level exempted from the donut hole?
Well, you don't actually hit the donut hole unless you use the extend beyond the limits that the initial provision of Part D.
Yeah, I know that. So the seniors that get into the above that limit, do poorer seniors have to pay if they get into the donut hole, the poorest seniors?
I want to make sure I'm giving you accurate information. They do not, sir.
They do not. And I think that number is 100, what is it, 135% of poverty, or is it a different number than that?
150%.
150. So the poorest seniors don't pay.
Yes, sir.
Under your proposal, would all seniors be exempted in this donut hole from having any expense?
Sir, we did not have in the budget closing of the donut hole. What I was referring to with the chairman is the provisions that are in both, and they're different in both the versions of the Senate and House health reform legislation. Both
Right.
majorities sought to close the donut hole, but our budget...
Well, since you talked about it, can we talk about it for a minute? Closing the gap, among other things, there's no disincentive, it would seem to me, for all seniors, including the richest seniors, not to use generic drugs, not to look for an alternative product if there's no reason not to get into this high level of spending. And what I've wondered about is if 150% of poverty isn't a good enough number to help seniors who can't afford it, what is the best number? This idea that all seniors, no matter how wealthy, deserve for the federal government through Part D to help them pay for their drugs doesn't seem to really benefit the system or be the kind of reforms we need in Medicare generally. And I'm just troubled by this idea that somehow all seniors are disadvantaged by this, and no matter how much money they have, they shouldn't have to worry about this donut hole. And do you have any response to that?
Well, Congressman, running for senator, Congressman, we would be happy to work with you if you'd like to talk about a cap or limit for applicability to close the donut hole. At this point, I think there is no differential if you're a wealthy senior or a poor senior.
Well, of course, there is a differential. You just said there was 150% of poverty.
No, I'm saying at the original benefits of the program, there isn't a differential. I think if you are ill, if you are wealthy or poor, you are much more likely to hit the cap than if you are in great shape. It has, I think, more to do with someone's health and well-being than to do with their economic
I actually
status.
thought it had to do with capacity to pay. The chairman said seniors should not have to go without their medicine due to lack of money. Now, I don't disagree with that at all. I do disagree with the idea that somehow this is a problem that can't be solved any way other than eliminating this one area where you have to think about whether you get above a spending cap or not. On the question of, I don't have much time, Mr. Chairman. I don't think I probably can. On the question of high-risk pools, I don't know, Governor, if Kansas had one or not. Missouri has, and we both use them. We're both familiar with them. Do you have any idea why there's no money in this budget for high-risk pools?
Well, Congressman, at least in Kansas, and I think it's true across the country, the federal government really provides very little in the way of support for high-risk
On this budget, they provide nothing.
I understand. It's about 2%, and what was anticipated with the passage of health reform that we would actually have a whole different situation with high-risk pools. Many of the people in Kansas in high-risk pools are those who are blocked out of the insurance market because insurance companies refuse to take them with pre-existing conditions. Health reform solves that piece of the puzzle. They'd have affordable, available coverage. So there was money in health reform for a new basis of high-risk pools that could create some stop-loss policies for those in a stopgap method between now and the time the exchanges are set up. But we anticipated that actually the high-risk pool, as they're seen right now, which is a very modest safety net, often way too expensive for most people to afford, would cease to exist. That's why the budget doesn't.
I think the percentage of the premium in Missouri is about 135% of what the normal premium would be.
Yes.
I'd certainly be glad to work with you on assuming that we're where we are today on this issue, that we figure out ways to expand access to those high-risk pools. And, Mr. Chairman, I'm over my time.
Gentleman's time has expired. Mr. Dingell.
Mr. Chairman, thank you. Again, Madam Secretary, welcome. Madam Secretary, there have been a lot of scandals and unfortunate news about food safety and foods. You'll recall last year this committee reported unanimously with the support of both sides My Republican colleague, Mr. Barton, was one of the co-sponsors, as was our chairman, and Mr. Pallone, and other members of this committee. That was a bill which passed the House with an overwhelming vote, and it is now sitting in, I hope, in a position where maybe we can get it up to the floor so it can get to conference and we can pass it to law. Do you have the authority you need now to protect the American people, yes or no, from unsafe food products, both in this country and coming in from abroad?
No, sir.
Madam Secretary, I am very pleased at the commitment to medical product safety in the bill and also to food. Do you believe that food and drug authorities have the authorities they need to carry their regulation in the 21st century?
Not at this time.
Now, in the bill that was introduced by my colleagues and I, and Mr. Stupak and the others, it had a number of things: annual registration fees, increased inspections, strong new enforcement tools, greater responsibility for manufacturers to identify and control risks, tougher scrutiny of ingredient and raw material supplies, documentation of safety for imported food products, and of course, the ability to see to it that good manufacturing practices are followed around the world. Do you need that authority?
Yes, sir.
Madam Secretary, I note that that has some $220 million in food registration and inspection user fees, and that those are in the President's budget. Are they necessary for the Food and Drug Administration to carry out its proper responsibilities?
Yes, sir, I think they are.
Madam Secretary, we now confront a serious problem about health care data improvement. The President has included $110 million for comprehensive health care data improvement initiative at CMS. The initiative appears to be a key part of the Medicare and Medicaid delivery system reform puzzle. It appears that the administration is on to something here. I have wrestled with a number of department agencies over the past of their adequacy and of their systems to upgrade these matters. They've had good motivation, noble intentions, but the implementation was also lacking, causing substantial waste and confusion. Madam Secretary, regarding the $110 million, is this to be a one-time investment?
No, sir. This is I think, a multi-year strategy to actually build a 21st century
Should we anticipate, Madam Secretary, that you will be coming back up here to continue to move toward adequate resources to sustain this project over the years?
Yes, we will.
Madam Secretary, one matter of concern. Will you provide the necessary and proper oversight of contractors and HHS employees responsible for seeing this project through?
Yes, and we finally have a information officer who also is helping us oversee this project, who is not directly connected with CMS.
Madam Secretary, is there a plan to consult appropriate stakeholders to ensure that all potential issues are properly identified and addressed?
Yes, sir.
And I'm sure, Madam Secretary, that you will do the things that are necessary to ensure a smooth and effective transition.
It's my plan to do just that.
Madam Secretary, last year the President signed a monumental tobacco bill into law. I'm pleased to see the administration's commitment to the FDA tobacco program in this year's budget. However, I have been concerned about the recent court activity surrounding FDA's actions related to tobacco products. Can you give us a very brief update here and then further information and a submission for the record on the progress of the tobacco program, and comment on the administration's thoughts on some recent unfortunate court decisions?
Well, Congressman Dingell, we're taking the responsibility to regulate tobacco products very seriously, and I would say approaching them
I'm satisfied you are, but I note that the courts have just recently said you couldn't regulate electronic cigarettes.
Right.
I note that electronic cigarettes were set forth as a device, which is a device which would inject narcotics or drugs into the human system. I note that the court has held that they are not. I find this most curious. I note you have appealed this matter, And I ask, do you need additional authorities to address that problem?
Well, once we hear back from the court, we may well be back in Congress with some requests for additional authorities. But we have a new center, we have a new director, we are publishing regulations, we've taken on the flavored cigarettes, we are looking at the avenues that were outlined by Congress, and when we hit a logjam, we may well return to you for legislative clarification.
Mr. Chairman, Chairman Dingell.
My time,
yeah, I don't want to, I know your time's over, and it's also that we've got
my
to
time's up. I'm willing to yield. Go ahead.
Thank you. We have 2 votes coming up, and those are the last votes of the day. But I am going to try to get two more people, so I just want everyone to know we're going to go to Mr. Deal if he's ready. And
yes, thank you.
Then we'll go to Mr. Engel, and then we'll break for the votes and come back. Mr. Deal.
Thank you, Mr. Chairman. Mr. Chairman, I would ask unanimous consent to include in the record the letter of September the 14th, 2009, was the letter that Mr. Barton referred to that was addressed to the Secretary.
Without objection, that'll be the order.
Madam Secretary, welcome.
Thank you.
I'm going to refer to a letter also. This is one that was sent to the acting administrator of CMS by Mr. Barton, myself, and Mr. Walden on June the 17th. It is a letter that asks for information as to the potential impact on state Medicaid programs with the proposed expansion of Medicaid under the House version of health care reform. And I would ask if you would, we have not received a response to this June letter, and I would ask if you would please try to get us an answer to that.
I will do that, sir. It's, we are collecting that data. It is not data that we hold and the states hold, and we're working on collecting that right now.
Thank you. In that regard, the best I can determine and the best information that we can get from CBO is that the House version would add about 15 million Americans to the Medicaid rolls and would produce about $34 billion in unfunded mandates on the states between the years of 2015 and 2019. Now, you mentioned earlier you'd been talking to governors about other issues. I wondered if you've talked to any governors who support this mandatory expansion of their state Medicaid programs, and if so, would you be courageous enough to tell us who they might be?
Sir, I've had lots of conversations with governors. Clearly, they would like as much help as possible on critical health needs, not only expanded FMAP, but if the state were, if the federal government were to pay for 100% of Medicaid coverage on into the future, they would be very grateful. They are appreciative of the notion that there's changes in the drug reimbursement rules also anticipated. There are changes in the way that states would be treated in terms of qualifying for various services. So we have tried on a case-by-case basis to give states regular kind of updates on what the impact of various versions of various measures were, and we'll continue to do that. Certainly the President's inclusion of the FMAP extension in his budget is an indication, I think, that he takes very seriously the state's situation with regard to FMAP. We're also working with a lot of governors on the dual eligible situation, which is currently one of the more expensive populations that any governor deals with, and looking at ways through our current CMS authority that we can give more flexibility to states, more innovative abilities to coordinate and manage care, and hopefully return some of those savings to states.
As you may know, one of the provisions of the House bill, which is Section 1703, with regard to expanded Medicaid and the enhanced FMAP, is the requirement that states enter into a maintenance of effort requirement. And our understanding is that that would prevent states from implementing any new procedures to reduce the prevalence of fraud in their Medicaid program, for example, because the language is that if it is more restrictive than the procedures in effect on June the 16th, 2009, and it may very well be that states would want to enhance their anti-fraud provisions and make it more restrictive than what was in effect last summer. I wonder if, as governor of Kansas, you would have taken very kindly to us telling the states that they would be prohibited from incorporating any new anti-fraud provisions into their state Medicaid program. And is that your interpretation of that section?
It certainly is not. I think that there's no question this administration and I think the Congress takes fraud and abuse very seriously. We've actually enhanced and have in not only the budget but in health reform a number of enhancements for fraud and abuse efforts. I think that the maintenance of effort language that you referred to has been in place since the Recovery Act was passed. It was defined to to governors. I was certainly, as I say, a governor at the time. No one ever suggested that maintenance of effort meant that you could not enhance anti-fraud efforts in the state. And in fact, we had very aggressive anti-fraud efforts in Kansas and have for years.
Does the maintenance of effort requirement that was part of the stimulus money, does that requirement expire upon the expiration of the stimulus funds received by the states?
Yes, it does.
Thank you, Mr. Chairman.
Gentleman's time has expired. Mr. Engel.
Thank you, Mr. Chairman. Madam Secretary, welcome. I have three issues which I'm going to raise quickly, and I'd like your comments on them. I chair the Western Hemisphere Subcommittee in the Foreign Affairs Committee, and I've been really grateful for all the wonderful support the Obama administration has given in the immediate and ongoing aftermath of the earthquake in Haiti. But as you know, the hard work continues. We expect a great number of Haitians to join their relatives in New York and in other areas of the country. And we welcome these children and families, but we need to ensure that our states and localities have enough resources to give them and our existing students the support and education they require. And as you know, our states and localities are already cash-strapped during this difficult economic time. Within the HHS Office of Refugee Resettlement, the Refugee School Impact Grant Program has stayed flat funded at $15 million for the past 5 years, even in this year's budget, which came out after the earthquake. In a letter that Senator Gillibrand and I sent you yesterday, we asked if the administration would support either a one-time emergency grant program for school districts that receive a high influx of Haitians, or alternatively, if you would increase the funding for the Refugee School Impact Program. While the broader Social Services and Refugee Program, which funds the School Impact Program, was granted an extra $25 million in the FY11 budget, your staff said the School Impact Program would be unlikely to see a bump in funding. I find that troubling. So I'd like to ask you, would you commit to working with me on this important issue to give our schools and communities the support they need if there is an influx, and we know there will be, of Haitian children putting strains on school districts?
Well, Congressman, we would be glad to work with you on all the ramifications of the Haitian situation, which, as you know, we're just beginning to try and sort out. But yes, I'd be very happy to continue that dialogue.
Thank you. Thank you very much. Madam Secretary, the New York delegation last week or the week before met with you, and I thank you for meeting with us. And we had a very good discussion about 9/11 health issues. As you know, and we had discussed it, all Americans 9 years after September 11th, first responders who came and were selflessly trying to save and help others now find themselves, because of the toxicity of the air, sick. We estimate there are about 20,000 people who are sick, coming from 431 of the 435 districts across the country. And some have died, unfortunately, others are disabled. We were hit, New York was hit, not because we were New York, but because we were a symbol of this country, and it is an ongoing fight in the war against terror. We had a discussion about whether the administration would commit to funding in the bill the health that we need, the health care that we need for this bill, and I know we're talking about it. So I'm just going to ask you if you would commit to working with us to pass a comprehensive 9/11 health care that's paid for.
I would very much like to work with you on that issue. As you know, the President's budget doubles the amount of funding in the project for 2011, and we look forward to working with you and others in the delegation on a long-term permanent solution.
Thank you. And my final question, in the last Congress, the ALS Registry Act, or Lou Gehrig's disease, a bill that I authored with my friend Lee Terry on the other side of the aisle, was signed into law. It came through this committee. It had great bipartisan support, and over in the Senate as well. I was disappointed, though, to see that the administration cut the ALS registry's funding by over $200,000 in FY11 from what Congress appropriated last year. And Congress didn't appropriate the full money. The act was authorized for over $10 million per year and is funded at just a little under $5.8 million. So to take $200,000 away from the underfunding of $5.8 million is something that's very disappointing. So I will ask you again, will you continue to work with me and with Congress to ensure that the CDC has the resources it needs to fully implement the ALS registry?
We are aggressively, Congressman, moving toward the implementation of the full registry, which we anticipate having online at 2011. The full funding that you refer to, the $10 million, is not essential during the planning phases, and the cut that you're referring to is really out of travel and some contracting cuts that the leadership of the CDC felt could be made without at all jeopardizing the implementation timetable or the full implementation of the registry. So we would look forward to working with you on that.
Thank you. And Mr. Chairman, may I just ask unanimous consent that in my letter to Secretary Sebelius on the funding for the HHS Refugee Resettlement Office be included in the record?
Without objection, that will be the order. Madam Secretary, we're going to take a recess. We have 2 votes, and as soon as we've completed the votes, we'll come back and reconvene. Thank you. microphone? Is it working? Okay. Committee will come back to order. Who seeks recognition? Gentleman's recognized.
Mr. Chairman, thank you, and Madam Secretary, we appreciate you taking time to be with us this afternoon. And last weekend, President Obama came over to Baltimore to meet with our caucus, and I'm sure you read some about that. And one of his comments that he made, we were talking about the right to keep your current insurance policy if this health care reform bill passes. And he said, I think some of the provisions that were put into this bill has violated my pledge to allow people to keep their insurance if they want to keep it.
Why would he say that?
And when I look at Section 202 of the House bill, which is about 3 or 4 pages in that section relating to protecting the choice to keep current coverage, there are all sorts of exceptions in here. And one of the frustrating things that I personally have is we keep hearing this, you can keep your coverage, you can keep your coverage, you can keep your coverage, and even the President said there were provisions put in at the last that cannot guarantee that. And now, is that your understanding, that there is no guarantee that a person can keep their current insurance coverage if this bill passes?
Well, Congressman, I can't speak for what exactly the President was talking about. I do know that in today's market, nothing ensures an employee that his or her employer is going to continue employer-based coverage. Nothing ensures that if you have employer-based coverage, that that employer will use the same network or the same doctors. That changes every day with contracts. So I don't know if that's what he's, I really don't know. But clearly there's not a way to guarantee. I think that the attempt has been to say we're not mandating, anybody have to move.
Well, I really appreciate your saying that because, I mean, to use his exact words, he said some of the provisions that were snuck in have violated that pledge. And when we hear people emphatically saying you have the right to keep your existing insurance policy, that's really not true. And so I'm delighted that you clarified that.
Well, in the current market, I'm saying absent any health reform legislation, there, no one is sort of guaranteed that.
Yeah. And one other comment I would just make, if this bill passes, we know that the coverage for Medicaid is going to be expanded, so the states normally pick up that cost, and we're trying to provide additional funds from the federal government because the states need it. The fact that bothers me about that is that the federal government needs money too. So basically we're got a program here that's expanding. It's going to cost the states more money, and because they need more money from us, it's going to cost the federal government more money. But the part of this process that has bothered me the most, and I think because I've heard so many comments from people not only in my district but really from all over the place, and that's the whole process when you're endeavoring to comprehensively change the healthcare system in America and you see side deals being cut when all of us represent the same taxpayer, and you see Nebraska getting a special deal, you see Vermont getting a special deal, you see Massachusetts getting a special deal, you see 3 counties in Florida where they're able to keep their Medicare Advantage program, and yet in my district where you have 15,000 people on Medicare Advantage that may not be able to keep theirs because of the reduction in money available for Medicare Advantage, it's just patently unfair. And I'm assuming that HHS worked with some of the staff on cutting some of these deals, which we understand is done to obtain votes. But as a citizen, does it bother you that if you're in a certain state or you're in a certain county that you get benefits that other taxpayers simply are not going to be able to have?
Congressman, I think that unfortunately it seems to be endemic of any legislative process that money is never distributed exactly equally, and it always is a problem for those who don't get the resources. And I think this is no different. But it's been my experience that is unfortunately a pattern, whether it's appropriations or where projects are cited or who's on the committee, or there often is not a actually equal distribution of any kind of resources, and I think it does make people unhappy.
Well, I do too, and I think that in the one area where we should get away from that is in the healthcare area, and thank you very much.
Thank you. The gentlewoman from California, Ms. Eshoo.
Thank you, Mr. Chairman, and welcome, Madam Secretary. It's wonderful to see you, and a warm welcome to our great friend who was with the committee for years, and I think will always be part of this family, and that's Bridget Taylor. It's really great to see you. Madam Secretary, thank you first for...
She's now part of our family.
That's right. That's right. But, boy, she was a longtime member of ours. You're lucky to have her. Thank you for your very, very thorough responses to letters that I wrote to you. I appreciate that. It took some time to get the responses, but they were worth waiting for because there were direct answers about exploring the use of adjuvants and vaccines and thimerosal, as well as promoting the new generation of cell culture-based vaccines, and on the issue of BioShield and BARDA. It is more than refreshing to see an HHS budget that emphasizes science. We got away from it in our country for too long. I think we paid a price for that because time is really the most precious thing that we're given. And for almost a decade, we lost that time relative to science. So rather than applying political science, we now are honoring science, and I think that that really honors the American people. I also would like to applaud many different parts of the budget because they are, I believe, and this budget is most frankly what I hear from my constituents, mostly about. Most of the emails, questions, faxes, meetings have something to do with your budget, with HHS. So I think it's a good one. Now, on the issue, I know that there's a emphasis on fraud and an effort to root it out, which I think is really very important. The last time we visited that was during the Clinton administration. That's a long time ago. I remember Secretary Sebelius sitting there and describing for us what they were undertaking. How much of a return do you expect from the HEAT effort? And I know that there's $1.7 billion invested in that. I mean, what do you think the return is going to be?
The most conservative estimate, I would say, is that we get somewhere $1.10 to $1.50 on every dollar invested. The Attorney General's numbers look more like 4 to 1. Our actual experience with the current fraud efforts are that we get somewhere between $14 and $17 for every dollar invested. So we have a wide range. What we know is we get back more than we spend.
Well, it's an area that is galling to the American people. I mean, there have been things on 60 Minutes, these storefront rip-offs. It really is the private sector ripping off the public sector. But I think that this HEAT effort better be white hot because there's a lot of money to be found in this, and I wish you well on that. The other area that I want to ask you about is the area of, as I mentioned earlier, on BioShield and BARDA. There have been dollars that have been moved around, not a lot, but you've moved, I think, 136 or 36 million or 136 million out of the out of one area to another, and that is the what I'm concerned about is the SRF, and you've moved some funding out of that Admittedly, it's not a ton, but I worry about what remains, because the whole area of developing and acquiring chemical, biological, radiological and nuclear medical countermeasures is very important for our country. I mean, we've just gone through H1N1. I think that's something that will look like something out of a seed catalog, God forbid, if we have a bio. If our country, God forbid, had to endure a bio attack. So, are you comfortable with that? I mean, why the movement of the funds? How much is left? I know that you said in your prepared remarks that there is going to be a report due on March 31st of this year. Maybe we can revisit this when the report comes to us. If you could see that the committee gets that ASAP when you put it out. But it is an area that Mr. Rogers and I both worked on, and I have a continuing interest in it, both from this committee standpoint and also from the other hat that I wear from the Intelligence Committee. And lastly, I want to say something. I know that, well, let me just say this. Obviously,
gentleman's got a few, is over, but go ahead and finish.
All right, I'm going to take about 30 seconds. And that is that our colleagues on the other side of the aisle are continually banging on all kinds of drums relative to health care. All kinds of ideas. Offer everything to everyone, cure everyone, give everyone insurance, and it's not going to cost a cent. I don't know where your budget is on this, but I think you need to put it on the table. Furthermore, most frankly, you were in control for a long time, and you're on this committee that has jurisdiction.
Gentlewoman is a minute over.
My question that I'd like to lay on the table is,
regular order, Mr. Chairman.
Regular order. Why didn't you pass all these things when you were in control?
Regular order, Mr.
All right,
Chairman.
let me move on.
Regular order, answer the question. You don't like it when someone raises it.
Gentleman
Thank you, Mr. Chairman.
Gentleman from Illinois, Mr. Shim.
Thank you, Mr. Chairman. And I think the benefit of having the President in Baltimore is that we did give him the package of GOP.gov, our solutions, which address many of these health care questions. And I would encourage my colleagues on the other side to take a look at those, because I do think there are, Madam Secretary, when we met with the RSC before the bill moved to the floor, I did talk about private insurance, a national health exchange, and a way to do it in a market-based solution. The Democrat leadership did not decide to go in that manner. I hope we relook at that. If we really want to move legislation to provide health care to all Americans, there is a compromise out there, and you can model it after Medicare D. That's what I proposed over, I don't know if it was a year ago, 8 months ago, but we could really get there if we shelve the centralized control, one big government solution, and go back to the market. But for my questions, according to the Congressional Budget Office, the House-passed health reform bill will add over 15 million Americans to the Medicaid rolls, producing $34 billion in unfunded mandates on states during the 2015-2019 period. Now, this is following up from Mr. Deal's question, which he asked, has any governor said, no, this is a bad idea? You failed to answer that question, and I'm wondering if, based upon, did you have any governors say, I don't want these additional unfunded mandates, because we know Medicaid requires the state, some states a 50-50 share, some states 70-30 share, depends on the state. Do you have any governors that said no, don't do this? The Medicaid expansion is bad. We can't afford it.
We have had governors who have expressed that they want more adequate federal funding if there is expansion, and other governors who are very enthusiastic about the plan. So we've had both.
So there are 35 states right now moving referendum against this, and I think the Virginia Senate just passed legislation through the Virginia Senate against the expansion of Medicaid, because
my understanding is that Virginia issue deals with a mandate to purchase insurance coverage.
Yeah, well, I think the 35 states that are, and we can address that, but the issue is the states are saying no, they can't afford it. Illinois is broke, California is broke,
And many states, as you know, Representative, are already exceed the 133%. So we have states that are kind of all over the.
And I would just say that expanding Medicaid to states who can't afford to expand it by a mandate, and that's where the debate comes. So then the federal government, which doesn't have a balanced budget requirement, that many states do, that's where then we pick up the tab and we go into historic national debt as we find ourselves today, just passing an increase. It's not mine. An increase in the debt limit. Let me go to. Would the President sign the Senate Health Care Reform Bill into law as it is alone?
Sir, you'd have to ask the President. Maybe you did in Baltimore.
Let me set the groundwork. When you came here the first time, the health bill was just in draft form, so you refused to ask any questions, take any questions on the health reform bill. You promised to return, which that never happened. So a lot of the frustration today is not having a chance to talk to you in the committee process to debate health care reform that was going to go through this committee. So that's where a lot of this angst. And now we're only given 2.5 hours to no one's allowed to give opening statements as a whole. And then they did extend it for an hour, but we had two votes in between. And that's part of the incredible frustration here. So does the President support cutting $500 billion from Medicare, as do the Senate and the House reform bills? Yes or no? I'll use the John Dingell approach. Yes or no?
The President supports the health reform.
So he supports cutting $500 billion from Medicare.
Supports making sure that Medicare is solvent into the future.
So that's a yes.
The overpayment.
The President supports cutting $500 billion. The Senate bill says $500 billion. The House bill says.
Well, they had different numbers in them, but the President.
So the President supports cutting $500 billion in Medicare.
The President
yes or no?
Supportive of the health reform legislation.
Is that a yes?
I said yes, sir.
Okay, thank you. Let me just talk about one issue that was hit on Mr. Whitfield. These three counties are what we talk about as Gatorade, the negotiated deal that Florida cut for their Medicare Advantage folks. These three counties, Palm Beach, Broward, and Miami-Dade, will not feel the effect of the Medicare cuts for Medicare Advantage. Was HHS involved in negotiating this deal with the Senate?
Sir, I was not.
No HHS staffer was involved?
Gentleman's time is over.
Okay. Thank you.
Sure. Gentleman from Texas, Mr. Green.
Thank you, Mr. Chairman, and welcome, Madam Secretary. And obviously our country's had a problem with excessive spending for decades. And I hate to keep reminding it, but my colleagues on the Republican side, we had a balanced budget in 99 and 2000, and we ended pay-go the next year or two, and literally for the first part of this decade, for the first 7 years, we spent without worrying about it. Everything went to the national debt. And now we're trying to do so many things with 10% unemployment. But let me get back to health care in the President's budget. First of all, I appreciate you being a longtime champion of community health centers and the sponsor of the most recent health care center, and as the sponsor of the most recent health care reauthorization that passed our committee in 2008, I want to commend the President's budget for the proposed increase in health center funding. Although it's below the amount we have authorized, given the physical constraints you're working with, I very appreciate this increase. Especially grateful the administration appears to propose that a portion of this increase goes toward ensuring that operating funds that health centers receive through the Recovery Act will continue. I know in my own district, a number of our community-based health centers expanded, seeing both more patients and actually hiring personnel that was part of the stimulus bill. Health centers have to date extended care to 1 million Americans using this funding and expect to surpass their goal of 2 million new patients by the end of the stimulus period. Can you confirm for us that you intend for existing health centers to continue to receive the funding in order to maintain the capacity to care for the new patients they've added over the last year?
Certainly, Congressman, it's our intent to provide resources so that the health centers can deliver care to the 20 million people.
And, you know, of course, community-based health centers really is a bipartisan issue. President Bush suggested increases that we tried to match. Because the district I represent has the highest uninsured rates in the country, I want to significantly expand the health centers program because their 40-year track record of providing high quality and cost-effective care. I support the efforts of the President to continue access to care for those 2 million served by the health centers through the stimulus bill, and to continue to grow the health centers program by providing that $290 million increase that's in the budget. Would you agree that this funding request is based on what you see as possible through the limitations in the discretionary appropriations process, that's even more significant growth through dedicated funding, or has been proposed in both the House and Senate reform bills, is still necessary? That growth is still necessary, even though we have seen both the House and Senate health care bills.
Well, I absolutely think that delivery of primary care services through community health centers is one of the great success stories, low cost, high quality care, and really dealing with the whole family. So I'm very supportive. I try to visit those centers wherever I go in the country, and they're remarkable community-based centers that deliver high quality, lower cost primary care.
And if we get to pass a health care bill, I consider that where the boots on the ground is our community-based health centers throughout the country. I also appreciate you being an outspoken proponent of the schools can play in vaccination, both with seasonal and pandemic influenza, and appreciate your leadership on that. I do have some concern. In 2008, I was a sponsor, and we passed the Tuberculosis Elimination Act that I strongly support increased fundings for TB. TB is the second leading global infectious disease killer, and because it's an airborne infection disease, it has always been a present danger in the U.S. Many states, such as California and Texas, where I represent, are struggling with steady increasing rates of drug-resistant TB, which is extremely costly and complicated to treat. Yet the TB will receive a funding cut under the President's proposed 2011 budget. Public health history in the U.S. has shown that cutting back on TB control programs can cause costly resurgence of the disease, such as happened in the U.S. in 1988 to 1992, when New York City had to spend over $1 billion to regain control of TB. Can you assure us that the states will adequately be equipped to protect our communities if we have outbreaks of additional outbreaks of the drug-resistant tuberculosis?
Well, Congressman, I look forward to having a chance to visit with you more about this issue where you clearly have some considerable expertise. Our new Director of the Centers for Disease Control and Prevention, Dr. Tom Frieden, did a large portion of his work on TB. He takes it very, very seriously. So I think, working with him and you to make sure we have the resources available is something that I'm committed to doing.
Again, thank you for being here. Mr. Chairman, I actually didn't ask for any extra time.
I appreciate it. Thank you. The gentlewoman from California, Ms. Bonomack.
Thank you, Mr. Chairman, and Madam Secretary, welcome. I have two brief questions, and I'd appreciate your insight regarding two requests I have pending before your department. Right now, at least 2.5 million adolescents suffer from substance abuse disorders, and surveys sponsored by your department show continued and increasing trends of the abuse of prescription drugs like Vicodin, Xanax, and in my opinion, the very powerful and deadly OxyContin. This problem has been largely ignored in the healthcare reform debate. I have concerns that proposed generalized programs like the Prepared Communities Program and counterparts at the DOE will dilute the important focus on drug addiction and prevention. So my question for you, my first question is, will you ensure that a clear focus remains on strategies aimed at directly preventing drug use and underage drinking?
I look forward to working with you on that, absolutely.
Thank you. Last year, I asked the FDA, late last year, some specific questions regarding a new formulation, which, from what I'm hearing, is it is not tamper-proof. Actually, it might allow the drug to be, OxyContin, to be even more abused. So I wrote the letter to the FDA with these specific questions. And so given the tragic abuse of prescription drugs among our nation's youth, I'm hopeful you can encourage your staff to respond to this inquiry.
I'd be very happy to do that. And Congresswoman, I would like to also have our new Director of the Substance Abuse and Mental Health Administration get in touch with you. As you probably know, substance abuse with prescription drugs is only slightly behind alcohol abuse right now and rising dramatically among children. It's an issue that she takes very seriously, has done a lot of work on. We're using her to help inform a number of our outreach and strategy efforts. So again, I think it's going to be a renewed and specific emphasis throughout our department.
I'm encouraged to hear that, and I thank you. I think it is very, very important for us to do that. Finally, I request your assistance with an issue that's important to our shared goal of rooting out waste, fraud, and abuse. In my district, the 45th District of California, a tribal TANF program is operating, and the tribe has received over $30 million a year on average to administer this program. It is troubling that government audits have shown a repeated misuse of federal taxpayer dollars, including federal allegations of misuse of $6 million alone in 2002 and 2003. Years later, penalties assessed to the program have still not been resolved. I recently requested that the IG at HHS and ACF investigate this matter further. The IG stated that the concerns would be best addressed by ACF. Knowing the charge of the IG's office, I hope that they and the ACF can aggressively seek answers and come to a resolution as to what happens, what appears to be years of insufficient accounting and wasteful use of taxpayer dollars. I fear that prolonging this problem only hurts the Native Americans for which the program was designed to serve in this difficult economy. Are you willing to consider protecting taxpayer dollars by withholding new funds until the situation can be resolved?
Well, Congresswoman, I must confess I'm not aware of this situation, but I will commit to going back and dealing with both head of ACF and the IG's office and putting together the information. I can't commit to anything until I know what the situation is and what the history is, but I will definitely take that as a personal commitment.
Thank you very much. I think it's extremely important. It is a very blatant example of this waste, fraud, and abuse, and it is hurting the people that are designed to be helped by this kind of a program. So lastly, I'm sorry that my colleague from California left, Ms. Eshu. I just would like to say that her questions about what has happened in the past on health care really ring hollow to my constituents. They care about what's happening today, and I can tell you that they do not like the government takeover of health care in any way, shape, or form. So I'm sorry that she's left, but I did need to say my frustration as well is pointing the finger. My constituents are tired of that argument. They want to hear that they want to have answers, and government takeover of health care is not what they want to hear. So I appreciate your being here today, and I look forward to working with you in the future. Yes. I yield back the balance of my time.
Thank you. Next is the gentlewoman from Illinois, Ms. Schakowsky.
Thank you, Mr. Chairman, and thank you, Madam Secretary, for being here and sticking with us this afternoon. I wanted to just make a comment about the exchange that you had earlier on the issue of the donut hole, and I wanted to make it very clear that as important as the low-income assistance is for people up to 150% of poverty, we have to understand how low in income that is and what difficulty people over that. The 150% of poverty is $16,250. And to suggest that seniors that make that much money can even think about getting out of a donut hole that's $3,500, it doesn't really compute for me, if you think about the other expenses. So based on your experience, is a $3,500 coverage gap just for prescription drugs, that doesn't count premiums and co-pays, just for prescription drugs, affordable for someone whose income is $16,500?
Well, certainly not at that income level. And while there may be, as I told the Congressman in his follow-up discussion, some individuals at a very high income level, I think typically we're talking about people using prescriptions who tend to be sicker, needing more medicine, which also is often a problem because they're spending more expenses on all kinds of other areas. So 150% of poverty is not a wealthy senior.
Is $20,000 a year? I'd even ask if $35,000 a year, if that's what you make, to get out of the donut hole at about $3,500. And these prices are exorbitant. And as you say, these are the sicker people.
Well, and unfortunately, I think what at least my experience is working with seniors is that too often there really is not a great deal of understanding of what's going to happen. So filling that next prescription, you are suddenly out of any kind of assistance, and you go from and you continue to paying your premium for Part
Absolutely.
D. So you pay a premium, and you're paying out of pocket 100% of costs. And what I know happens all too often is people just don't fill the prescriptions, cannot take the medicine, can't keep themselves out of the hospital or out of work.
That's why
Gentlewoman's time has expired. A lot longer, actually, than I realized.
I thought we had 5 minutes, no?
Well, you're 2.5.
Mr. Chairman, I don't think she was started. I don't think her time was started properly.
Oh, okay.
Oh, no, I'm sure.
All right, well, keep going then.
All right. That's why I prefer the House bill, of course, that actually does eliminate the donut hole altogether. You may not have the answer because it's kind of an esoteric question, but I want to pose this to you, and maybe you can get back to me. We have some nursing home reform advocacy groups in Illinois, Illinois Citizens for Better Care for one, and this is a problem that was brought to my attention. Recently, there was a change that means they can no longer obtain Aspen survey data on disk, but have to get case-by-case reports on paper, which is a big cost burden and time burden to them. So I hope that you'll review that decision in order to reduce the burdens on small not-for-profit groups that do inspections, they monitor how nursing homes are doing, and of course it's a huge problem, quality care in nursing homes, and to ensure transparency. So if you could just look into that, unless you know.
We'd be glad to and get back to you about that.
Okay, thank you so much. I yield back.
Thank you. Who's next? Mr. Terry is next.
Yes, thank you. Governors, appreciate you being here. First of all, what is your understanding of where the health care legislation is today? Are there plans that you're discussing with the White House and congressional leadership to move one or the House bill or the Senate bill, or is there a movement to that you're aware of to throw those two away, start anew, where we could focus on consensus items?
Congressman, I think there are lots of discussions going on. As you know, the House passed a bill and the Senate passed a bill.
Well, I asked you what is your understanding, not what other people's
telling you what my understanding is. Lots.
Oh,
of
I'm sorry. You said that you didn't know what other people were doing. So
no, there are lots of discussions going on.
So you're not going to answer the question?
There are lots of discussions going on. That is the answer to the question. There is no one.
Okay, then would you be
discussion.
specific about the ones that you're involved with? Of what are the options? I'm sorry I wasn't more clear in my question, evidently.
Congressman, I think depending on who you talk to, any number of options are on the table. Start again, start with an
What are the options that you're advocating?
I don't have a single advocacy piece other than let's move the health reform forward. I favor, as the President does, a comprehensive plan. I favor looking at the similarities in the House and Senate version and hopefully finding a way to move comprehensive legislation forward as quickly as possible.
Okay. During the exchange with the gentlelady, this wasn't on my list to ask, but I have to now.
Which gentlelady?
Ms. Eshoo. There was a comment that you agreed to that in regard to looking for fraud, nothing has been done since the Clinton.
Sir, that was her statement.
Well, you agreed with it because
I sat here.
Do you agree? Well, let me ask you. Do you agree that the Bush administration has done nothing in 8 years to find fraud and waste? Because that was the statement, and you didn't counter that at all.
Sir, I don't have any expertise on what the Bush administration did or what the Clinton administration.
Is it your opinion they've done nothing?
Pardon me?
Is it your opinion they've done nothing?
It is not my opinion one way or the other.
Okay,
I don't
well,
want
you
to
didn't
offer
correct
an
the
opinion.
gentlelady, so I assume since you had the opportunity to say there's been efforts. Well,
I'm really
with the
not.
HEAT program in place, wouldn't it be beneficial that you looked at what past administrations have done?
We certainly have looked at what past administrations have done. I know.
So what has the Bush administration done? You just said you didn't know.
I'm very sorry.
You're
I'm happy to
confusing me.
go
I'm
back and
sorry.
document. I don't want to give you incorrect information. I'm not an expert on what the Bush administration did, or as Congresswoman Eshoo said, what the Clinton administration did, so I didn't enter into that discussion. I'd be happy to come back and report to you. There clearly has been a fraud and abuse effort underway. There never has been the effort put forward by this president, which asked the Justice Department and HHS to collaborate and cooperate at the cabinet level to put strike forces on the ground to try and get out ahead. It's been a pay and chase operation, often auditing, sometimes well after the fact, that has been in place for a long time.
Okay. Very good. With durable medical goods, I've had some of my pharmacies back home tell me they have yet to get their inspections, even with the extension that Congress passed to allow them to get their appropriate license to sell durable medical goods. Is there another effort by HHS to give them an opportunity to get licensed, or whatever the appropriate language would be? It's already been extended once.
I can't answer that specifically, but I'd be happy to get back to you. I don't know the reference, the time frame that you're referring to.
Well, it was, yeah, I only have 28 more seconds. Last, in the environmental health section of the budget, it's reduced a little bit. There's two programs in here that I would appreciate you taking a look at. One is the Healthy Homes Child Lead Poisoning program. That's an extremely important program in Omaha. We're a Superfund site for lead, but if you ask our health folks, they'll tell you that most of the lead poisoning that's occurring is from unhealthy homes that are significantly older than 1973. So for that to be one of the programs cut is a concern to me. The other is the ALS registration, which seems to be already below what the CDC has said they need to do the registration, and that's ones that cut. One that was is a new program put in that seems to be sucking up a lot of the money from the programs that is cut is the Built Environment and Health Initiative. Can you tell me what that is?
Congressman, I'm sorry I cannot, but I would be happy to get that answer back to you.
I'm just curious. Thank you.
Thank the gentleman. Next is the gentlewoman from the Virgin Islands, Ms. Christensen.
Thank you, Mr. Chairman, and thank you, Madam Secretary, for being here. We appreciate the increases that we're seeing in the 2011 budget, and hopefully we can do some more with health care reform as we move on from here. You know of our commitment to stopping the preventable early excess deaths in African Americans and other people of color, and yet as I try to get a handle on what's happening in the department, I seem to sense a moving away from focusing on racial and ethnic minority populations in the department's efforts to eliminate these huge disparities that have existed for far too long. So one of my questions, which applies to the Office of Minority Health, the National Center for Minority and Health Disparity Research, and the National Minority AIDS and Education Training Center, can you reassure me that the needed focus on the racial and ethnic minority populations will continue, not because they're minority populations per se, but because they are so disproportionately burdened by disease? And would you support, as we're trying to do in healthcare reform, the and in other standalone bills as well, the strengthening and expanding of the offices of minority health to other agencies and the elevation of the National Center for at NIH to an institute?
Well, Congresswoman, I would definitely commit to you that there has been no lack of focus or attention or interest in closing the gap in health disparities, which continue to be alarming and appalling. And the new Assistant Secretary of Health, Dr. Howard Koh, also takes that very seriously, and he is the umbrella agency supervising a number of the offices that you have
So the Office of
described.
Minority Health, for example, will stay Office of Minority Health. It's not going to change the disparity and move away from minority that you know of.
I'm sorry.
It's going to stay Office of Minority Health. The Office of Minority Health will continue to be the Office of Minority. With all of the other AIDS education and training centers open to everyone, and given the need for cultural competency and the fact that over 70% or more, 70% or more of the new patients with HIV and AIDS are people of color, we have this one national minority AIDS education and training center. It works with all of the minority serving institutions, community-based organizations from every race and ethnicity and group. But it seems as though HRSA is changing how they're dealing with this particular center, trying to fix something that's not broken, putting barriers in the way of minority serving institutions continuing to provide this service at a time when minorities are still disproportionately burdened by HIV and AIDS. So do you know yourself what's happening with the National Minority AIDS Education and Training Center, and is there a move within your department to open that up to every majority institution, better funded, better able to compete, or can we try to keep that within a minority serving institution?
Well, again, Congresswoman, I think the very good news is that President Obama has taken very seriously the commitment to have a very aggressive domestic AIDS HIV agenda, feeling that while the focus of PEPFAR has been a great success globally, we have really not paid as careful attention to what was happening in the United States. And as you just stated, the overwhelming number of new infections and new cases are focused directly in the minority community, in African Americans, in Latinos, in American Indians. So first I would tell you that I just participated in greeting and swearing in the new Pacha Council, a diverse and very committed group of individuals. We intend to have a very aggressive focus that's well-funded, and our office is clearly a part of that. And I will have that conversation with Dr. Wakefield.
Understanding the need to focus on racial and ethnic minorities who are hardest hit. And I'd just like to get in a word about ADAP. $20 million this year, $20 million next year. They need more than $200 million to end the waiting lists. We'd like to see a stronger commitment to ensuring that everyone with HIV and AIDS has access to treatment, and not lose sight of the fact also that not only will people die without being, as they wait on these waiting lists, but that treatment is a major form of prevention as well. And so it's very important that we try to close that gap for ADAP.
Gentlewoman's time has expired. Thank you. Gentleman from Texas, Mr. Burgess.
Thank you, Mr. Chairman. Madam Secretary, last week, I hope you're aware that this committee took up the business of a resolution of inquiry to obtain documents from the White House and from your department on deals that were made with 6 major stakeholders early in the health care reform debate. Thanks to Chairman Waxman, we had a unanimous vote in this committee in support of obtaining many of the documents that I think the committee really should have to see how the legislative process might have been circumvented. So Chairman Waxman and Ranking Member Barton will be delivering to you a letter detailing the 6 areas where we would like more information. Do I have your commitment to work with Chairman Waxman and this committee to obtain those documents from your department?
Yes, sir.
Now, yes, thank you. Yesterday, you testified at Senate Finance that you and your staff were not involved in health care reform negotiations. Was that correct testimony to the Senate Finance Committee yesterday?
Mr. Chairman,
Thank you.
Mr. Congressman, what I testified to was that I don't have a vote in the committee, and I have certainly been present at not only dozens of conversations with members of Congress in the White House. I've traveled all over this country talking to stakeholders and seniors, doctors and nurses, teachers, union members. I have been involved literally in hundreds of
Okay, I'm sorry, I'm going to interrupt you because time's going to run out. What reported the New York Times yesterday, quoting you, I'm not a principal in the negotiations. So you were present, but...
What I said is we play a role of providing technical advice and assistance. We certainly have encouraged people, but I don't have a principal's vote. I've been a member of the executive branch and the legislative branch. I'm not a legislator at this point.
I'm not meaning to interrupt, but in Politico, in December the 2nd, it was reported that there were strategy sessions that involved yourself, Interior Secretary Ken Salazar, White House Health Czar Nancy Ann Mindeparle, and White House Deputy Chief of Staff Jim Messina. Is that an accurate reportage? Is that an accurate assessment?
I have no idea what they're referring to. I have certainly been in the room with those folks, and I will go through my calendar and give you information. That
gets then to my question. Will you be willing to provide us any notes or emails that you had, for example, with the healthcare czar Nancy Ann Mindeparle or the White House Deputy Chief of Staff Jim Messina?
Sir, I will look at the request. We'll talk to. I will look at the request as it comes to me and assure you we'll get back to you.
Well, here's the frustration. I mean, we're the committee that's charged with writing the legislation. And the President, to his credit, last March said that he was going to set boundaries and deadlines, but the committees were going to write the legislation. And then we find out that last May and June, there were all kinds of deals cut with AdvaMed, the American Hospital Association, AHIP, and Pharma down at the White House, the AMA. We don't get to be privy to any of those deals. The AMA endorsed the bill before we even got it in committee. What did they give? What did they get? Why did that happen that way? Why was it in the Senate Finance Committee last fall that Senator Nelson, when he was trying to work some of the cost cutting that was going on, the whole bill had to go back to CBO to be scored because the hospital said we had a different deal. You can understand the frustration at the legislative side with trying to deal with legislation that's this complex, and we all agree that it's complex, and yet we don't know on the legislative side what deals you've made on the administrative side. So that's very frustrating, and in fact, I think it disrespects the role of this committee to not be privy to those discussions that were carried on behind closed doors, especially when the President promised over and over and over again that this would be a transparent process. You mentioned that in your opening statement, that transparency was going to be critical, and yet we've had nothing that resembles transparency. Everything has been opaque from the administration in regards to how these health care deals were worked out.
Well, again, Congressman, I would suggest this conversation basically has gone on for a year. There have been hundreds of hearings, lots of C-SPAN coverage, lots of public forums and town hall meetings over and over and over again. 3 different committees in the House, hundreds of amendments.
Well aware of
Senate,
that. I don't need to hear that recitation. But the Senate confirmed you as the President's principal health care advisor. Is that correct? You went through the Senate confirmation process?
Secretary, yes.
And then it seems like, and what you tell this committee, what you told Mr. Terry is, well, you're really not a principal in these negotiations. Is that because the President doesn't trust you to carry on this type of negotiation?
Congressman, what I said yesterday, and I'll say it again, is I am not a principal to vote on the bill. I am not a member of the legislative body. I'm a member of the executive branch.
You are the primary advisor to the President of the United States in health care policy. You were confirmed by the Senate. Is your obligation to be a principal in these discussions?
The gentleman has expressed his opinion. We got to move on. Next is the gentleman from North Carolina, Mr. Butterfield.
thanking you for being here today. I know it's been a long afternoon for you, but thank you very much for your patience. Let me also thank you for your leadership throughout this whole health care reform debate. I happen to believe that you have been an integral part of this debate, and you have played a very valuable role in this this debate. And even though my friend from the other side of the aisle may feel that you were not at the table, I believe that you were. So thank you for your leadership. Madam Speaker, I am particularly interested in the area, Madam Speaker, Madam Secretary.
All right, I made that.
You are not in the legislative branch. You made that point very clear. But I'm very interested in the area of health IT and the investments made in the Office of the National Coordinator of Health IT. Your testimony makes mention of the administration's plan to encourage the adoption of electronic health records through Medicare and Medicaid incentive payments, as provided in the recovery bill. I think this should be applauded, and I appreciate the leadership the administration has shown on the issue. I must express some concern, however, with the proposed rule issued by CMS on the definition of meaningful use of EHRs, however, particularly regarding the requirements for hospitals and doctors to receive the incentive payments. How will rural hospitals, including critical access hospitals, be able to meet these objectives? I happen to be from a low-income district, and you and I have had that conversation many times. I have a very low-income district. How will districts like mine be able to with major chronic health issues prevalent among constituents, how will those hospitals that serve low-income communities, and how often and how few financial resources? Let me try that one again. I represent anytime you try to put your own language in there, it kind of bothers the flow. So let me try that again. I happen to represent a low-income district with a major chronic health issues prevalent among constituents. How will those hospitals that serve low-income communities have the resources to meet these objectives? Can you help me with this?
Certainly, Congressman. I think that as you know, the Congress anticipated that the Office of Technology would develop a definition for meaningful use. It was part of the legislative mandate. It's part of the law moving forward. And there is an assumption that small providers, small critical care hospitals, those who are not necessarily as technologically savvy right now, haven't started this process, may need more assistance, which is why I think wisely the legislation also anticipates these regional extension centers, which will be available, and their primary charge is to focus on underserved areas, to focus on more reduced poverty populations, on hospitals and providers who need additional assistance. So that's part of the framework that is moving forward. So there'll be financial incentives, but more than that, there'll be actual practical help, resource centers, kind of hands-on assistance.
But it's not only the small hospitals, it's the medium-sized hospitals as well. They
really
just don't have the resources
to
meet these objectives.
Well, the resources it will be part of the incentives as the bill moves forward. That's part of the as quickly as people are ready to become part of meaningful users, again, with assistance and help and support, they'll be able to qualify for the payments that Congress allocated in the measure.
Let me conclude by thanking you for your support for community health centers. That's a big deal in rural communities, as you well know. You have been very sensitive to our needs. This administration has been sensitive, and the President's budget speaks to increased community health centers. The bill that we reported out of this committee was very strong on community health centers, and I just want to thank you and urge you to continue to support the concept of community health centers. They're very valuable in low-income communities. Thank you.
You're welcome.
All right. I yield back.
I thank the gentleman, and next is the gentleman from Georgia, Mr. Gingrey.
Chairman, thank you. Madam Secretary, thank you for your patience in staying with us. We have an entitlement crisis on our hands, and the unfunded liability, as you know, Madam Secretary, for Medicare alone is $35 trillion by the year 2075. $35 trillion. And if left unaddressed, this obligation alone could ruin our future economy. Yet in the President's budget, this $3.8 trillion budget request, I don't see any concrete proposals to improve the Medicare solvency outside of the $251 million that you mentioned in your budget to increase to fight waste, fraud, and abuse. Surely there are more initiatives available. They certainly are needed to strengthen the Medicare program for our seniors. Why are there no other initiatives included in the budget request so that we can extend the Medicare solvency?
Well, Congressman, I think that, again, the budget is put together as a companion piece to a number of the features in health reform, and we hope to be able to move forward aggressively in both fronts, moving toward more of a coordinated care strategy on bundled payments, which is a way to actually ensure that we can do everything from reducing the return of 1 out of every 5 Medicare patients to the hospital and keep folks not only healthier but at home, working on hospital-based infections, which not only kill 100,000 Americans a year but actually cost hundreds of millions of dollars year in and year out. Those strategies are very much a part of the look forward. We're beginning to focus more of the payment on primary care and general practitioners, recognizing that keeping people well at the front end.
Madam Secretary, I'm going to interrupt you. I have a couple of more questions I want to ask. I agree with you on that point. Certainly, wellness is the way to go rather than waiting until people get sick, and I certainly don't disagree with you on that as a physician member. You know, the mandatory part of our budget is probably 60% of our spending, and yet in the President's budget, there's some shifting of some of the discretionary spending, particularly on the money that was going to be given to the states to help create these high-risk pools. I think something like $55 million, and make that mandatory spending. It makes it easy, of course, to freeze discretionary and fulfill his pledge to do that over a 3-year period, but it seems to me it's pretty irresponsible to create additional mandatory spending of any amount at a time when we're suffering so badly with these $1.6 trillion deficits as far as the eye can see. Would you agree with me that creating additional mandatory spending is certainly not in our best interest?
Well, I think any additional mandatory spending needs to be looked at very carefully. I would certainly agree with that.
I thank you, Madam Secretary, and I appreciate that response. Let me ask you one quick last question, and you know from previous times that you've been with us, I've always had some concern over the amount of money that we spent on H1N1 and where that money goes and what we do with the amount that's left over, and indeed what we do with the vaccine that's not used. Under the CDC portion of the budget, I see there are $225 million listed as balances from the pandemic flu fund that was passed in June. Just to be clear, how much of the original $7.7 billion that was given to the President in June to combat H1N1 virus remains? How much of that money has been unspent at this point?
Congressman, I don't want to give you an incomplete answer. What I would very much like to do is give you a very thorough breakdown of where exactly the money has been spent and where it is. I know that a portion of the supplemental funding, the 209 supplemental funding that was designed to deal with the H1N1.
Madam Secretary, fair enough. If you would give me I know you don't have time now, and I want to ask you one last thing, but if you'll give me a report on that, I would very much appreciate that. If you would get back to me in a timely fashion. The last thing, real quickly, in regard to the stockpile of H1N1, what percentage, or how many people have we actually reached that have been vaccinated? Of the remaining stockpile, and what percentage actually of the stockpile remains? What happens with that next year? Can we utilize that in any way, any effective way, or do we have to just discard it?
Well, Congressman, my last numbers from CDC are, I think we're in the 64, 65 million range in terms of people who have been vaccinated. States are continuing to order vaccine. As you know, just at the first of the year, the vaccine opportunities opened up, so seniors are beginning to be vaccinated. Populations who weren't in the high-risk pool are being vaccinated. And what is happening is that the bulk antigen is absolutely able to be used for future vaccinations. The fill and finish has a more limited time period, so there has been an attempt not to fill and finish every amount of the bulk antigen that has been purchased, and that's being looked at as this. But the states are continuing to order vaccine, and so we're looking at that issue very carefully.
Madam Secretary, thank you. Thank you for your patience, Mr. Chairman. I yield back.
Thank the gentleman. Gentlewoman from Florida, Ms. Castor.
Thank you, Mr. Chairman, and welcome, Madam Secretary. The collective cheer you heard from Florida families and hospitals last Friday afternoon was a result of your efforts to work with us on a 1115 Medicaid waiver, an amendment to that, and I want to thank you very much, and Cindy Mann and Bridget Taylor and your entire team for helping us get that done. And then you came to our aid again this week because HHS rightfully activated the National Disaster Medical System because after the January 12th earthquake in Haiti, hundreds of evacuees have come to the state of Florida for medical care and treatment that's not available in Haiti. In fact, the state of Florida has treated 618 people from Haiti who were injured in the earthquake. Many are still in our hospitals receiving treatment, and that National Disaster Medical System will help. It's helping evacuated Americans and Haitians, and we really appreciate it. Here's my question. How long will it remain activated?
I think, Congresswoman, that's a question that we're not quite sure that we can answer right now. What was clear in the conversations with your governor and other state officials like yourself is that the disproportionate brunt that Florida was bearing did not seem appropriate when there was really a national and international response to the crisis. So the effort is to stand up medical care in Haiti as quickly as possible. To a number of the people being evacuated right now are actually doing post-op care. They have surgical treatment on the USNS Comfort and then need to be brought somewhere for care. That hopefully will be available in Haiti in the very near future. There's a 325-bed hospital that should be up and running within days, literally, that can be expanded to 1,000 beds, doctors and medical supplies being gathered. So the government of Haiti and others would far prefer, frankly, that we help build those assets in Haiti, and that's what really the international community is responding to. So this is a stopgap, but right. I can't tell you exactly how long.
Okay, so we'll continue to have a dialogue on that. And Florida's Department of Children and Families has begun repatriation efforts for more than 20,000 Haitians following the earthquake. Under the current law, Haitians who are granted temporary protective status are considered Cuban Haitian entrants and are therefore eligible for medical federal assistance such as Medicaid for 7 years after they arrive in the United States. Consequently, Florida, and I'm sure other states, will have a sizable number of newly Medicaid-eligible residents for years to come. Does the administration's budget consider this? I know that the budget probably was mostly put together before this time, so, well, does it consider this?
No, the budget really was put together before the earthquake hit, and so we are having conversations not only in our agency but government-wide about what this assistance needs to include.
Good. So you'll continue to work with us.
And your Office of Children and Families has been absolutely spectacular.
Well, I appreciate that. I'll pass that on to the Secretary. Would this be handled through FMAP or some other means, or we'll have that dialogue going forward?
Well, currently, Congresswoman, there are lots of alternatives. Our Office of Refugee Assistance is one. There are other avenues, but those conversations are really underway.
Okay. In a somewhat related vein, you know, there are many states that are prone to natural disasters. For example, in Florida, in recent years, we were hit by 7 hurricanes, and this skewed our FMAP calculation because after the hurricanes, we had a huge run-up of reconstruction and jobs, so that when the recession hit, the formula really hurt us. We didn't have the money coming in under FMAP. Now, fortunately, through the Recovery Act, we've made some of that up. But I'd like to look at a permanent solution for states that run into these kind of problems so that at the worst time we're not penalized just because of a post-disaster run-up in employment. Would you work with me on that type of solution, or do you have any recommendations at this time on how?
No, I think that's a very real issue and problem that is not unique to Florida. It's been experienced by a number of states, and I think there are also a number of members who think that the entire FMAP formula needs to be revisited, so this could be one aspect of that.
Thank you very much.
Gentlewoman's time has expired. Gentleman from Maryland, Mr. Sarbanes.
I know you're delighted to see me because I'm the last one to ask you questions.
Always delighted to see you, Congressman.
Thank you. First of all, I want to commend you on your remarkable composure, which I judge as remarkable because if I had to sit where you are sitting and bear some of the hectoring that you've borne today, I don't think I would have been able to exhibit the same composure, and you don't have to respond to that. I do want to say that I think you're doing a wonderful job in your position, and you have a bearing which I think will stand the agency in good stead and has been very effective in dealing with the public on all manner of issues, including the H1N1 flu virus and others. And we're really blessed to have you there. It cannot have been easy to put this budget together, given what a moving target the health reform bill has been. And regardless of what happens with that reform effort, your work will remain really at the center of the health system, in particular the public health system. And so I thank you for the work you're doing, and you've clearly put together a tremendous staff that I know is working around the clock on these issues. There's so many good things that are in those health reform bills, and many of them are ones that your budget reflects as well. And I just wanted to point to a couple of them and ask a couple of questions. First of all, there's a discussion of, these Medicare demonstration projects and some other initiatives to determine how to better align provider payments with the kinds of outcomes and treatments and regimens that we want to see. I've been long fascinated by the I think overemphasis on procedure reimbursement versus time spent with patients. And I wondered if you could just speak to whether some of these demonstration projects are intended to determine how we can enhance outcomes and treatment approaches if we look to providing better reimbursement so that physicians can be rewarded for spending a little extra time with their patients.
Well, I think that that is certainly one of the outcomes that would be most desirable, not only providing financial incentives to spend more time, but certainly the kind of coordinated care strategies which we know work well with not just physicians, but sort of medical teams that following a patient's release from a hospital can be much more effective keeping that patient well and healthy and on a pathway to success. So we've added Medicare to a demonstration project that's going on in the Northeast, which we think can bear great success. We know that too often physicians, and Dr. Gingrey, you may have this experience, talk about not being able to see people on a regular basis to keep them well, but they get the incentives tilt toward sick care and not health care. So I think we've got a great deal of opportunity to move into that preventive care wellness strategy space with financial incentives and other strategies to make sure providers can be providers.
Great. I wanted to congratulate you on the resources going towards the National Health Service Corps, enhancing the number of primary care providers out there, and other initiatives which include as a component of them helping students with the debt burden that they carry. That's something I've been particularly focused on across the board, and authored a provision that actually the President mentioned the other day relating to loan forgiveness for those who go into public service. So I really encourage that effort. The last thing I'll just mention, because I'm running out of time, is I'm very interested as well in this idea of what I call place-based healthcare, which is to think about how we, instead of relying on the patient to come to our healthcare system, we think about how we can bring the system to the patient, and think about where people are already gathered, where there's a captive audience. The most obvious example of this is schools. And I would love to continue to work with your office on all things school-based when it comes to health initiatives, because I think there's tremendous opportunity there to provide screening and preventive services and other things, potentially even help with the enrollment around CHIP, although I know that's something that has to be worked through perhaps on a state-by-state basis. But there's tremendous potential there. And you know that the H1N1 outbreak in New York City, for example, was spotted by a school nurse. And there's so much more we can do to enhance the public health infrastructure of the country if we focus in on these places where people already are. So I look forward to continued efforts in that regard as well.
Well, Congressman, I think not only is your effort in that area appreciated, but one of the great success stories of H1N1 will be the school-based vaccination clinics, where schools really were great partners. They were even better when there was a school-based health clinic that was then reaching out to the parents and grandparents and younger siblings of those children. I can tell you that the new Secretary of Education and I have already had discussions about how we can accelerate and encourage more school-based health clinics, because I agree with you, it is a great way to provide cost-effective health care and reach folks where they're comfortable and coming on a regular basis. And unfortunately, the number of school-based health clinics is kind of frozen. There was a large investment, and then it's kind of flattened out. But I think the way community health centers have become, part of the infrastructure, I think school-based health clinics also need to be looked at as one of the ways to expand access site and deliver low-cost, high-quality preventive care, not only to children, but to their parents and grandparents, to the neighborhoods around the schools, and have the schools be a health center.
Well, thank you, Madam Secretary. And gentleman's time has expired.
Mr. Chairman?
Yes.
I ask unanimous consent for a second round of questions.
Mr. Chairman, you object?
Is the gentlewoman from Florida, she's the one who objected? I just want to identify which person objected in the front row.
All right, look, yes.
Is it the gentlelady from Florida?
She did object.
Object to a second round of questions to the Secretary.
Will the gentleman please?
I like to thank her.
Look,
Mr. Chairman, point of order.
Let me just respond to you. The chairman, Chairman Waxman, made it very clear from the beginning that what we were doing is having everyone have 5 minutes to either ask questions or make a comment or whatever. It was quite clear that we were not having a second round and that that's what we were doing today. So I'm not going to proceed to a second round, because I think it was quite clear from the beginning that that's not what we were doing.
A unanimous consent request, Mr. Chairman, just for anyone to have questions to be able to submit them to the Secretary.
Yes, absolutely. I know you.
I don't know if that question was made prior to the.
No, I know that you have some written questions you'd like to submit to the Secretary. I know others will. So we will allow, we always do, but I'll specifically say today that we will have some written questions, and we'd like you to get back to us in a timely fashion with those, Madam
Mr. Chairman, will there be a time limit that we expect these responses to be made? As we saw, some came quick, quite a few came long.
I believe that generally speaking, but I don't want to put you in any kind of a straitjacket here, but generally speaking, we ask the members to submit those questions within 10 days, I believe. And, I would ask that, for whatever you get within those 10 days, that you get back to us in a reasonable time,
Mr. Chairman, is this the last time we'll see the Secretary this year before this committee?
I certainly hope not. I thoroughly enjoy seeing her. And
Well, I mean, part of the frustration is we have the head of one of the largest departments in the federal government, and we have 3 hours with her.
I understand. I don't want
with
to make
the major policy decisions that healthcare has been, with the promise that she would have been here after the rollout of the bill, which never occurred. So that is our frustration, and we would like to have more time.
Well, we're not doing it today. We'll see if there's another opportunity, but I don't want to make any commitments at this time. But I do want to thank you for being here today. And I know it was suggested that it was tough. It wasn't really that tough compared to some of our meetings. But we do appreciate all that you've done, really, not only on health reform, but also on all the different health issues that come before your department. Thanks so much. And without objection, this committee is adjourned.